Good morning. Welcome to another edition of Extended McMaster Perspective. We have a privilege to host Professor Gordon Guyatt from Department of Medicine and Department of Health Research and Impact at McMaster University. And as most of you know, he is also really the ideological father of evidence-based medicine. So I'm really privileged to have him. The goal of this extended McMaster perspective is to explore the changing landscape of diabetes mellitus treatment. And I plan 3 separate interviews with Dr. Guyatt, who is a methodologist and internist, treats this patient, but here is mostly as an author of numerous meta-analysis and practice guidelines in this area. I will hope to interview an endocrinologist, an opinion leader as well, and nephrologist who could provide some more information. So the impetus to those interviews gave 2 recent publications in which Gordon was the lead person. One dealing with SGLT2 inhibitors in people with renal dysfunction, and the other was choice of diabetic drug in a general diabetic population. Gordon, any questions on your part at this stage, or any comments you would like to make?
Only comment is thank you for still thinking I'm worth talking to.
Okay, so I will share the screen and I will go to the first paper I would like to talk about. Could you tell us a little bit what led to it and who did it, and to some degree how what was done before we go to the results?
Clearly, as you have said, there is an evolving perspective. And if you were a nephrologist, you were very unhappy for many years because there was nothing you could do that could prevent, except perhaps ACE inhibitors in diabetes, nothing you could do to prevent progression of renal disease to renal failure. And now the situation has changed, and the nephrologists in general are delighted that they now have other medication that can prevent progression, and the SGLT inhibitors are perhaps the best of those. So clearly we wanted to get the message out to people. We wanted to summarize, and we believe, of course, that we need systematic reviews of the highest quality evidence available to give the best summaries, and our clinicians and patients deserve such summaries.
So the starting point of this particular medications was diabetic treatment. Did you look at diabetic population or expanded it to different, not necessarily
all populations in which it's been used? And one of the things with the SGLT inhibitors has been that it doesn't matter whether you have diabetes or not. So for instance, people with heart failure, it's going to reduce your admissions for heart failure, irrespective of whether you have diabetes or not. And it's going to prevent your progression of your renal failure, whether you have diabetes or not. So where it started with diabetes turns out for those 2 important outcomes, admission for heart failure or renal failure, doesn't matter whether you have diabetes or not. Effects are similar.
In this paper, which we are referring to, there were patients with diabetes and renal dysfunction, and people with renal dysfunction without diabetes.
Correct.
Okay. So which outcomes have you looked at? What were the outcomes of interest?
You're going to, I think, interview me about another paper, and I might get confused between the 2 in terms of exactly what we looked at. But The outcomes that are relevant from a clinical point of view are mortality. The SGLT2s reduce mortality. They reduce admissions for heart failure. They reduce progression of renal failure. They reduce myocardial infarction. So all the major vascular events and renal failure and all-cause mortality, SGLT2 inhibitors are effective.
Do the effect depend on risks of patients?
Oh, of course. So to put it at the extreme, if you're a 30-year-old with diet-controlled diabetes and no other morbidity, your risks of dying in the next decade are very, very low, and nothing can make major decreases in risk because you have almost no risk, to take an extreme example. So, and of course, nowadays, that goes true for treatment of hypertension or prevention in people at risk. The low risk people are only going to get small benefits because they are at low risk. And thus, it becomes discretionary about use of these agents, becomes discretionary in the low risk, perhaps shouldn't do it in the very low risk. Anyway, as the risk goes up, the arguments or the compelling reasons to use these agents goes up.
So how can clinicians establish the risks or judge the risk?
There are various risk calculators around for cardiovascular risk. There are methods for renal risk, and the papers that we are talking about, including the papers here, describe ways of getting at the risks. And when we were doing these papers, we looked at all the various ways of establishing risk. None of them are perfect, but in general, you can say you're older and you have diabetes and your creatinine is higher, are the major factors that are going to determine people's risk.
So unfortunately, if you are young and healthy, you have low risks. If you are older and ill, your risk goes up.
That's right. And if you're young and healthy, you may not want to be taking these drugs. Even if you're older and healthy, you may not want to be. Like me, for instance, I don't. Although I'm old, I'm still healthy. And so my risk is sufficiently low that I'm not interested in taking medication.
Okay. The conclusion from that would be that we are talking about risks. Are we talking about relative or absolute? Did you find?
We are talking about absolute. So I will, although if tomorrow I have a myocardial infarction or develop diabetes or develop some degree of renal dysfunction, my situation now, when I have none of those things, and my situation if tomorrow these terrible things happen to me, the relative effect of these medications is identical. In other words, for mortality, there is, for the SGLT2 inhibitors, don't remember the exact numbers, but between 15 and 20% relative risk reduction. And that's the same for me while I'm healthy, and it's the same for me once I get sick. So the relative effects are same across risk groups. And that, by the way, is a general phenomenon across just about everything we use in medicine. Relative risks are similar across risk groups. On the other hand, the absolute risks are much, and the absolute benefits are much greater. As the sicker I get, the more I'm going to benefit, ironically enough, perhaps. So the high risk groups get the benefits. So absolute depends on your baseline risk a lot.
So to summarize this part, we both work in hospital. We both see patients who have diabetes or not, but have significant renal dysfunction and who are older, who may have heart failure, who may have albuminuria and so forth. And it sounds to me that in each of those occasions, we at least should ourselves to ask the question and maybe talk to patient about use of SGLT2 inhibitors. Like in the not remote past, we were asking the same question about using ACE inhibitors. Are we at the similar level of potential benefits here?
Yes, we are. It's certainly the relative risk reductions are a little bit less than they were with ACE inhibitors, but still enough that for the high-risk patients, they're going to get appreciable absolute risk reductions.
Okay. So that answers and maybe even finishes the first part of my discussion with you.